Great, thanks. I'll just dive right in. Thank you for the introduction. So yeah, at Barts Health in the lung cancer service, we're currently introducing a new digital intervention, and it's a mobile phone app aiming to support patients with what we call prehabilitation. So prehabilitation is essentially pre-operative optimization, where we're getting patients fitter for their lung cancer treatments, most commonly lung cancer surgery, but also could be radical chemoradiotherapy, for example. So the app is called the Living with Lung Cancer app, and it has different features to support patients with their prehabilitation, including an exercise plan, goal, symptom and weight tracking, medication reminders, patient-reported outcome measure questionnaires, a library of lots of information for them to access, and a way to directly message the clinicians. So it's an exciting new intervention for us. However, we know that rapid engagement with this digital intervention will be essential for good outcomes, and that's because patients will only be using this app for a maximum time of, say, 4 to 6 weeks before having their lung cancer surgery, for example. Barriers and facilitators to the use of a digital behaviour change intervention in this setting has never been explored. You also know that, of course, that Barts Health serves a very diverse population of East London with a wide range of ethnicities and areas experiencing socio-economic deprivation. And this population set may therefore experience increased barriers to engaging with a digital intervention. There's this issue of digital exclusion, whereby there may be additional barriers such as internet access, digital skills, motivation and trust concerns. And of course, we know in the lung cancer population, due to the association with tobacco dependence, there is an increased association with those experiencing socioeconomic deprivation. So it's really important to include these people in our studies. So just briefly, what I'm planning on doing is a mixed methods project with a qualitative and quantitative studies. So firstly, we plan to recruit 30 patients from the lung cancer clinic at Barts. It'll be those patients who have a likely new diagnosis of lung cancer and have been offered the Living with Lung Cancer app to help them prepare for treatments. They'll be asked to complete a baseline questionnaire, including demographics and other important factors, such as their ability to access the internet. And then after using the app for 4 to 12 weeks, we'll be asking them to undertake semi-structured, in-depth interviews to explore their experience when using the app and undertaking their prehabilitation activities. I'll also be interviewing 20 healthcare professionals at Barts Health who currently already support patients with prehabilitation and using the app to explore their perspectives on what the barriers and facilitators to using the Living with Lung Cancer app are. There's also a quantitative arm whereby I'll be recruiting patients in exactly the same way, but after 12 weeks, I'll be collecting the app usage reports, which will be information on how often they're using the app, how many minutes per day, for example, and how many activity actions they have completed. And I'll be using this information to look for associations with patient characteristics and further identify any inequalities in its use. And the overall aim of this study is to essentially optimise patient uptake and engagement with the Living with Lung Cancer app. And that might be done by, for example, optimising the app itself, such as its interface, the features and the timing of digital stimuli, which is relevant and motivating. We aim to achieve patient benefit by promoting behavioural change in the form of self-care and exercise, improving patients' cardiorespiratory fitness and performance status, and allowing those with borderline fitness to then safely undergo potentially life-saving procedures and reduce their post-operative complications. Empowering patients to self-manage will also reduce clinic time and healthcare costs, and identifying factors which may lead to health inequalities can be used to identify those patients who might require extra support. So addressing inequalities is a big theme throughout my study, and this just shows the different ways I've thought about how I can address inequalities throughout my study design. Now, I'm still in the early stages. I've completed the study design. I'm currently applying for ethical approval, but I just thought I'd quickly go over one way I've tried to think about addressing inequalities in designing my study, which was by doing some patient and public involvement work. So I was very lucky to be awarded a PPI grant from the Centre of Public Engagement here at Queen Mary's to allow me to carry out these activities. So I wanted to include participants from underserved communities, ideally those that had lived experience of cancer, I recruited people into my activities through a variety of different methods. Firstly, via the community routes, via Tower Hamlets Health Watch. I used the lung cancer PPI group at Barts Health and the CSPED PPI panels and pools. And essentially, I released this poster to advertise my PPI activities, and people were able to contact me via email or via phone. I carried out 3 different PPI meetings discussing different topics. Firstly, the first meeting looked at the study design. I wanted to find out what people perceived of my research plans, how it should be conducted, the research questions which were a priority from their perspective, and importantly, recruitment strategies to ensure I achieved a diverse sample. I wanted to have a look at my recruitment materials, so that included my consent form, my patient information sheet, and the baseline questionnaire, ensuring that I used user-friendly, plain languages and targeting my specific communities. And finally, the last meeting would discuss the questions in my interview topic guide for the qualitative interviews to ensure that my questions were asked sensitively, were easy to understand, relatable and important from their perspective. I also created a PPI evaluation plan, but I did think I had a little bit longer for this presentation, so I'm going to just skip this in the interest of time. So for the participants who engaged in my meeting, so there was 3 male, 6 female. 1 had a personal experience of lung cancer, but all had experience of cancer either personally or via close friends and family. 4 of those people lived in East London, and this pie chart shows how I had a really diverse group with regards to ethnicities, which is particularly important for me. Just very briefly going to talk about the insights, maybe just highlight a few important ones just in the interest of time, and then I want to go over my last slide. So for my study design, I guess one of the most important things which was highlighted was how I'm going to be recruiting patients. Participants suggested I recruit patients at the 2nd lung cancer clinic appointments, and that's because people often have the breaking bad news part in the 1st lung cancer clinic appointment, and often that's where people, of course, may become upset, and which will affect appropriateness to recruit, and of course it's an information overload. With regards to trying to achieve a diverse sample, quite basic but important things discussed were including family members, carers and people that they trust during these discussions, using interpreters, using simple language and constantly checking understanding. With regards to the recruitment materials, I'll just give one example from here. So with regards to the patient information sheet, this is obviously quite a long document. There's lots of information that we do need to include. And I had thought about having translated versions, for example, in Bengali, one of the most important widely used languages in East London. However, people often said that if many people may be able to understand by hearing their language, but may not be able to read it, and therefore one suggestion was using audio patient information sheets, which is something I will consider. I'm just going to go on to the last slide now, so I think I'm only meant to have 8 minutes. So one last thing I wanted to discuss was some of the learning points which I had from conducting these PPI activities. I guess one of the main issues were people perhaps diverting from the agenda of the meeting. So some participants maybe not quite understanding the purpose of the PPI meeting and wanting to discuss other things. My solution for that would be releasing pre-meeting information, really setting the scene at the beginning of the PPI meeting, giving clear purpose and agenda, and gently guiding conversations back if they do divert elsewhere. There's always the issue of dominant individuals sometimes in these discussions, and the way I got around that was by asking people directly and sort of going around the group to ensure that everyone had a chance. One issue was actually some participants didn't have very much to say even when directly asked, and I perhaps that's maybe due to lack of experience with PPI, but I'm not too sure. Yeah, that's everything. Thank you.